So let's talk about some ortho MCQs, and there are around 46 that I've created in this video, and 46 MCQs are there. So let's get started. The first one is osteogenesis imperfecta. The mutation is in the col1A1 and col1A2. So remember that col1A1 and col1A2, they are the ones which are responsible for osteogenesis imperfecta. Then there's something called as Van der Hoos syndrome, and it's got a triad of three features. One is fragile bones, one is blue sclera, this is blue sclera, and one is deafness. So you have fragile bones, you have blue sclera, and you have deafness. So BBD, or you can also call as VDH. Now coming to the next one, which is also called as marble bone disease, and it is actually another name of osteopetrosis. Marble bone disease is another name of osteopetrosis, and it is when there's decreased osteoclastic activity. And another name for this is the Albers-Schonberg syndrome. So there are three names for this. One is marble bone disease, osteopetrosis, and Albers-Schonberg syndrome. And what you see in this is a characteristic bone within bone, endobone, that is called as. You can also see Ragger-Joshi spine. Ragger-Joshi spine is also seen where in renal osteodystrophy. So remember, Ragger-Joshi spine is not a very specific sign. It is seen in marble bone disease, also called as osteopetrosis, also called as Albers-Schonberg disease, and it is also seen in osteodystrophy. And marble bone disease, there is osteopetrosis, there is decreased osteoclastic activity. The next one, the fourth one, is the Z. Now, when you're talking about osteoporosis, remember that there are two scores which are involved, Z score and a T score, and this is osteoporosis, and there are two scores which are involved, Z and T. Now Z score is, you remember Z as same or same, whatever, so the same age, gender and ethnicity, whereas a T score is when you're always T score is when you're comparing with a young man which is 30 years of age. So where, how do you say it's osteoporosis, where the Z score is less than 2 and the T score is less than 2.5. So you remember that is important. Z score of less than 2 and T score of less than 2.5. So we spoke about what is Z score and what is T score. Coming to the different characteristics of the vertebra in different diseases. So the first disease we have is the Lincoln log disease. Lincoln log is actually like an H like this. So that H shaped is seen in sickle cell disorders. There's something called as picture frame vertebra, which is seen in Paget's. Remember, a picture frame looks like this, and there's a man inside who's Paget. So you can remember this picture frame vertebra is seen in Paget's disease. Then there's something called as vertebra plana. Vertebra plana is seen in lots of conditions, osteoporosis, including osteogenesis imperfecta, osteomyelitis, and even trauma. All of these conditions you see a vertebra plana: osteoporosis, osteogenesis imperfecta, osteomyelitis, and trauma. And the last one, which we already spoke about, which is the codfish vertebra. This is seen in osteoporosis. Codfish is seen in osteoporosis. This is very well asked. Codfish seen in osteoporosis. So the next one is let's talk about the investigation of choice for osteoporosis. This is a very important question. They'll confuse with bone scan or CT or X-ray. The most investigation of choice is DEXA scan and should be done every post 65 years in women. 65 years is the cutoff. It should be done regularly in women, and more than 70 years in men. Then that these are all the different treatment options for osteoporosis, and they always ask you which drug is what class. So remember, donozumab is actually a rank L drug inhibitor. Then there's an alendronate, which is a bisphosphonate, teriparatide, which is a PTH analog. You can remember this as parathormos or PTH, alendronate as bisphosphonate, so NATE, and denosumab is actually like an antibody type of thing, so you can remember that. Then strontium ranelate is actually, it is a sort of like it acts like calcium. It increases the bone formation while it decreases the resorption. So that is also the strontium. Coming to the next thing, called as a loser zone. Every time you see loser zone, you remember osteomalacia. You can remember this as a malicious person. A malicious person is a loser. So this loser zone is very much characterized as in osteomalacia. So you can remember a malicious person is mostly a loser. So this loser zone is seen in osteomalacia, and it is actually an incomplete stress fracture. Coming to something called as a hemangiopericystoma, and these are tumors which are associated with osteomalacia. This is a very unusual question that is asked. Hemangiopericystoma is seen with osteomalacia. Okay, and coming to the ligaments, which is the ACL ligament, which is anterior cruciate ligament. In there are two signs which are can be demonstrated for ACL tear. One is an anterior drawer sign, one is a Lachman sign. Now, anterior drawer sign is not preferred for an acute painful knee because the patient will not allow to go into 90 degrees, which is required for this test. Okay, 90 degrees flexion. So, anterior drawer neck is not for acute. Okay, not for acute knee, which is acute painful knee. In that conditions, you use a Lachman test. The next one is rotational injuries. Now, rotational injuries are mostly going to cause your meniscal tears, and most commonly medial over lateral, because medial is more immobile as opposed to the lateral one. Medial is more immobile, that is why medial meniscus is more commonly involved in rotational injuries. Coming to your cruciate ligaments and meniscus ligaments, they are actually intra-articular. That means they are inside the joint, cruciate as well as meniscus, and that is why they are going to be associated with blood in the joint, which is hemarthrosis. The next is this patella baja and patella alta. They are basically a low-lying and high-lying patellas. So you can remember as high is A is high and B is below. So in that order of A, B, C, D, A is high and B is below. So high and low. So remember a low lying, which is a baja, is not responsible for recurrent dislocation. The question is, what are the different factors responsible for patella dislocations, recurrent dislocations? Remember, low lying patella is not going to be responsible. The next is a Thompson's test point, which is they'll give a scenario where they'll show you two different legs like this, and one leg, the back of the leg, that is a heel region, will be swollen, and the other one will not be swollen, be a normal one. So the swollen is actually a Achilles tendon rupture, and there'll be some different, like athlete or some history of an athlete doing some very exerting this thing exercise, and it's going to lead to a rupture. That is Achilles tendon rupture. So your heel, at the heel you get a swelling, and you'll also get this Thompson's test point. So Thompson's test point and Achilles tendon rupture. Next is these casts. These are different casts which are used, and you can remember this knuckle bender. So knuckle has knuckle bender. You can remember this. So this U stands for your ulnar. So your ulnar palsies you will use a knuckle bender cast, whereas a radial palsies you use a cock up class. You can remember what cocks are rad, or just it sounds very inappropriate, but that's how I remember cock up radial. Next is your pin, which is posterior interosseous nerve. So remember, just ask posterior interosseous nerve causes what, and the main thing is extend it. Basically, you will not be able to extend your MCPs, which is the metacarpophalangeal joints. So MCP, extension of MCP is done by pin. So a pin palsy will cause failure of extension of MCP. Now there are three degrees of nerve injury. This is also very commonly tested: neuropraxia, axonmesis, and neurotmesis. So you can remember this as the last stage is where your nerve is rotting. Last stage is where the nerve is rotting. So that is the third stage. You also have neuropraxia, which is whenever you first stage is when you practice. So you can remember neuropraxia, so that's the first stage. Second stage is axonmesis, and third is neurotmesis. So it's NAN. The last two are all knots. One is a knot and one is a rot, and the first one is a practice. So practice, not rot. Coming to your thumb, all thumb muscles, all the muscles in the thumb are supplied by median nerve. Remember, all the muscles of thumb, be it abductor, be it flexor, be it opponents, everything except adduction. Adduction is carried out by the ulnar nerve. So you can remember, you add the ulnar adds basically. So ulnar adds. So in thumb, all by median except adduction, which is by ulnar. The next one is the basically all the tumors. This is very commonly tested, the tumors. The most common benign lesion is a non-ossifying fibroma. This is a lesion. Okay, when they say lesion, it is a non-ossifying fibroma. So non-ossifying fibroma is the most common benign lesion. But when they say most common benign tumor, then it is osteochondroma. How do you remember this? Like osteo stands for bone, chondroma stands for cartilage. So most common benign tumor is going to be something which has bone and something which has cartilage. So osteochondroma. But osteochondroma is not a true benign tumor. So when they say what is the most common true benign tumor or bone tumor, then it is osteoid osteoma. So this I remember by TBBT or even TBT is double O. Okay, TBT is double O. That is osteoid osteoma. That is a true benign. It's a true. Okay, remember when the true word comes, it is O. That is osteoid osteoma. Now remember OO, and you draw one more O around it. This O around it is actually a tablet, which is an aspirin tablet. So remember, osteoid osteoma is very much responsive to aspirin. Next is a fallen fragment or a trapdoor sign. This fallen fragment or trapdoor sign comes many times and is seen in simple bone cysts. Where it is seen in simple bone cysts. All cysts, all the cysts which are there, be it ABC, be it simple bone cysts, they all are metaphyseal in nature. And remember, because they are in the metaphysis, especially simple bone cysts, they can cause some growth abnormalities. Coming to which is where, remember two things in both epiphyseal tumors and diaphyseal tumors. Epiphyseal tumors, the mnemonic is epic giants chondroblasts. Remember, epic giants chondroblasts. Basically the chondro silent, so epic giants blasts. So epic giants chondroblasts. So epic stands for epiphyseal, giant stands for your giant cell tumors, which is GCT, and chondroblast stands for chondroblastoma. Whereas your diaphyseal tumors, you have to remember, you have two wings. Always remember there are two wings. So the two is basically diaphyseal, and so E wings is diaphyseal, and two O's are because there are two O's. So that is also diaphyseal. So remember, for diaphyseal, remember the two term. E wings is two wings, and double O's, so two O's. Okay, they all are diaphyseal. ABC and SBC, which is aneurysmal bone cyst, and simple bone cyst, are metaphyseal. Coming to osteoclastoma, Brown's tumor, all the cysts. So remember, all the cysts, the osteoclastoma, osteosarcoma, Brown's tumor, all of these will have giant cells there in the histology. Now there are different bone X-ray mein what do you see and what do they indicate? So if there's a Shepherd's crook deformity, then it is a fibrous dysplasia. Shepherd's crook, fibrous dysplasia. Onion peel is E-wings. Fallen fragment or a trapdoor sign is simple bone cyst. Winking owl is vertebral metastasis. Okay. Polka dot, corduroy or jailhouse sign is seen in vertebral hemangioma. This is also very important, very often tested. Polka dot, corduroy, jailhouse is seen in vertebral hemangioma. Winking owl is there in vertebral metastasis. So metastasis and hemangioma we did the simple bone cyst also. Onion peel is E-wings. Shepherd's crook is fibrous. Moth eaten is multiple myeloma, MM. Okay, remember that. Popcorn is chondrosarcoma. So popcorn, chondrosarcoma, onion peel, E-wings. These are all the food ones. Now coming to there are four syndromes actually. McCune Albright, Mazabrod, Mafuji, and Olios. McCune Albright is very, very simple. There are three things that you have to remember in McCune Albright. There's polyostic, osteotic fibrous dysplasia, also called as PFD. Written it as PFD, polyostotic fibrous dysplasia. Along with that, they have cafe ole spots, which are rough in the edges. Cafe ole spots which are rough in the edges, and they have different endocrine increase, so different endocrine abnormalities will be there. So McCune Albright, three things. First thing is they have PFT, which is polyostotic fibrous dysplasia. Second is cafe au lait spots, which are rough edges, and the third thing is the endocrine increase in the endocrine hormones. Then there's also Mazabrod syndrome. So this you can remember both of them together, McCune Albright and Mazabrod. Mazabrod also have PFD, which is polyostotic fibrous dysplasia, but they have myxomas. And the characteristic of PFD with these myxomas and Mazabrod syndrome is that they are when they are presenting together in a syndrome, the PFD and myxoma behave differently as opposed to when they are present in individually in different individuals. So we did McCune Albright and Mazabrod. Coming to Maffucci syndrome. Maffucci syndrome has two things. One is multiple enchondromas along with hemangiomas. So enchondromas with hemangiomas, multiple. Okay, that's the keyword. Multiple enchondromas and hemangiomas. And the next one is the Olier's syndrome, where there's only multiple enchondromas. So Olier's and Maffucci are similar. M stands for multiple, so we have multiple enchondromas with hemangiomas, where Olier's stands for only one. So there is enchondromas. Now, one thing you have to remember is that Maffucci can transform into a chondrosarcoma. Coming to osteochondroma, one MCQ, very lame MCQ, is that osteochondromas, the most common presentation for pain is when there is a bursitis present. So osteochondroma when will present with pain when there's bursitis. Coming to Trevor's disease, there's something called as Trevor's disease, is when there's intra-articular epiphyseal osteochondroma. So inside the joint, when there is towards the epiphysis, when there are osteochondromas, that is called as Trevor's disease. And one osteochondroma pain will be there when there is bursitis. Next is Langerhans cell histiocytosis. Now Langerhans cell histiocytosis, you have to remember three things. Is this man called as Lan? This land man has basically something on the head, on the skull, which is map shaped. So that is called as geographic skull. Also, there's a hole-in-hole appearance in Langerhans cell histiocytosis. You can see there's a teeth. There's one tooth which is floating. So that is a floating tooth. And here you have the vertebra, which is vertebra plana. So this land, you remember the head has skull, as a geographic skull, floating tooth, and vertebra plana. This is Langerhans cell histiocytosis. Next is chondroblastoma versus LCH, which is Langerhans cell histiocytosis. They are quite similar in a way of histology, where both of them have grooved nuclei with eosinophilic cytoplasm. They have a grooved nuclei with a eosinophilic cytoplasm. And how do you differentiate between chondroblastoma and LCH? Is that you'll do this test of CD1A. CD1A. Now CD1A will be present in LCH. CD1A will be present in Langerhans cell, whereas it will be absent in chondroblastoma. Coming to hemangioma, a hemangioma will present with a localized gigantism. You don't normally do a biopsy because it bleeds, hemangioma. And it is present in the vertebral body and skull. We already spoke about the findings in the vertebral body, that polka dot, corduroy sign, along with jailhouse sign. But if it's there localized, you get gigantism. Localized, don't do biopsy, body and skull. Next is most common malignant lesion of the bone is metastasis. Most common metastasis is from the breast, followed by prostate, followed by lung. So BPL. These are the mets which come, and this is the most common malignant lesion of the bone. In child, it is neuroblastoma. Remember, in child, the most common malignant lesion is going to be neuroblastoma. Coming to osteosarcoma, the osteosarcoma is a pulsatile tumor. Remember, you follow T10 protocol to treat osteosarcoma, T10, and the histology is you get pleomorphic cells plus osteoid. You get pleomorphic cells plus osteoid. So this is osteosarcoma. Whereas chondroblastoma, you get chicken wire calcification. If you can remember, this is fine. Chicken wire calcification is seen in chondroblastoma. So we spoke about osteosarcoma, chondroblastoma, hemangioma is seen. You can remember this as not hemangioma. Sorry, adamantonoma is seen in tibia. The most commonly seen in tibia. This I remember as adamant tibia. Next is Ewing sarcoma. Ewing sarcoma is a tumor which arises from the bone marrow. Okay, so remember that it arises from the bone marrow. Ewing's comes from the bone marrow, and it has the translocation of T1122 and 2412. 1122 and 2412. You see small blue cells. Okay, this is blue. Small blue cells are seen, and this is Ewing sarcoma. You get PAS positive and reticulin negative. So PAS positive, small blue cells, translocation 1122, 2412, bone marrow. Coming to your something called as a 5 salliferous cells. 5 salliferous cells are seen in your chordoma. Seen in chordoma. Next is your osteolytic sarcomas, osteolytic secondaries, mixed secondaries, and blastic secondaries. So osteolytic L, so you can remember everything with L, renal, malignant myeloma, multiple myeloma, malignant melanoma, and thyroid tumors. So you have your L's and thyroid. Mixed may you see, remember you have your lungs and breast over here. So these are your mixed M, like this. This is M. So mixed. So that is seen in lung and breast. Blastic is seen in prostate, osteosarcoma, and medullary carcinoma of the thyroid. So prostate, osteosarcoma, and medullary carcinoma. POM is where you see the blast. Okay. Pompe, blastic. Okay. Next is there's a score called as Mangle Extremity Severity Score and Limb Salvage Score, Ganga score. So that MES, Ganga, and limb salvage, they are all used for amputation. Next is PVD is the most common cause of amputation. There's something called as Jaipur foot. Jaipur foot looks very normal, low cost, can use an uneven ground, and you can squat. So these are the 4 characteristics you see in Jaipur foot, which is preferred in India. Whereas the SACH foot is not, as it is basically the opposite of this. Okay, it's basically the opposite of this. So Jaipur foot looks good, low cost, uneven ground, and squatting. Next is the Lisfranc and Chopard. Remember Lisfranc, you have to remember TMT. Lisfranc, Lizzie Frank is a TMT. Just remember TMT, Lisfranc. That's the only thing you need to remember, Lisfranc, TMT. That's so basically this amputation passes through the tarsometatarsal junction, whereas the Chopard is TT. So you can remember the T in the Chopard is the last letter. So it's a basically transverse tarsal amputation. You have your preoperative radiation, which prevents heterotopic bone formation. This is just a random MCQ which comes which of the following makes it causes heterotopic bone formation, and one of the options is preoperative radiation. So it basically prevents heterotopic bone formation, radiation. Now coming to DDH, that is a developmental dysplasia of the hip. Now this developmental dysplasia of the hip has a lot of tests. There's Barlow, there's Ortolani, Gerlisi. So how do you remember everything? Barlow, low. So basically you put pressure to remove the femur head either outside or low. So go low. Basically femur head go low. That is Barlow. And Ortolani is when you put pressure to put it back in. So in the Ortolani, the NI flip it into IN, and in. So basically you're putting the femur head back in. Galizi test, remember this as Gal, Ali, Z. So Gal stands for girls, so DDH is more common in girls. Ali is a sign which is seen in Galizi sign, and basically it's when you flex the hip and you flex the knee, you'll see that the one which is there'll be a discrepancy in the height. So the height will be low in DDH, and there'll be a height difference on flexion. And there are these two lines, Perkins and Hillgreners. You can remember ER and Perkins stands for ER and vertical. So this Perkins is a vertical line, whereas the H in Hilgerinus is actually a horizontal line. And in DDH, the femur head will be located UO, which is upper and outer. Upper and outer. Now, metabolic disorders of the bone. So there are different disorders. This a lot of questions are asked in permutation combination. You see the you see the minerals first. If the minerals are off, see the parathyroid and vitamin D. Now, if the parathyroid is increased and it is hyperparathyroidism. If the vitamin D is decreased, rather it can cause rickets and osteomalacia. This is to do with the calcium or all the other minerals, phosphate, calcium, whatever is there. Mineral disorder, parathyroid, vitamin D. Coming to the matrix, which is collagen disorder. So there are two collagen disorders. One is osteogenesis imperfecta, which is a pro-collagen disorder, whereas scurvy is actually a vitamin C deficiency. So you have osteogenesis imperfecta and scurvy. Now, if there's a cells disorder, is basically cells made of blasts and clasts. So if there's a clastic disorder, clastic means there's increased function and decreased function. So if there's an increased function, it is Paget's, decreased function is osteopetrosis. We already spoke about osteopetrosis being also called as a marble bone disease, also called as a Albers-Schonberg disease. And basically there's decreased function of the osteoclast. Increased function is Paget's, decreased function is osteopetrosis. Whereas low bone mass, so overall is just a quantitative effect of the bone, which is going to be because of osteoporosis. So we spoke about minerals, we spoke about matrix, we spoke about cells, osteoblast, osteoclast, and we spoke about low bone mass.